of the lights. So. Okay. That was me. Hello, everybody. Today we are going to talk about the Journal Club, Critical Care Journal Club. This Journal Club was pretty much based on. I'm rounding right now in the ICU, and we are seeing a lot of patients that are coming with sepsis from the emergency room that receive fluid resuscitation as part of the protocol. They are receiving a good amount of crystalloids. So what I'm dealing right now in the ICU is what type of crystalloid should I give? Should I continue with the normal saline, or should I switch to LR? And usually my practice so far has been waiting and see how is the chloride in the blood. And when the patient is hyperchloremic, I decide to switch to LR. That's based on the premise that LR has less content of chloride. But I really want to know what's the best option, and why, if we are switching to LR, why should I start resuscitating these patients with LR instead of normal saline? So that was my question starting this journal club. So I found this article. Unfortunately, I couldn't find any clinical trial, but I found a good cohort study that was published in 2014 in a critical care journal. And the title of this study is Association Between the Choice of IV Crystalloid and In-Hospital Mortality Among Critical Ill Patients with Sepsis. So this is a cohort study. So before that, I just want to talk about a little bit about crystalloids. And because in this study, they are going to talk about balanced fluids versus non-balanced fluids. So usually the commonly available crystalloids, especially in our hospital, are normal saline and LR, or lactate ringer solution. So what's the difference between a balanced fluid and a non-balanced fluid? So basically the idea is that the balanced fluid is, the composition of that fluid is close to plasma. So there's an important difference in the chloride content, and also in the strong ion difference that will give us, in plasma, the strong ion difference is around 40. So the idea of giving a balanced fluid is some type of fluid that is going to be close to that, so we are not going to have any acid-base disturbance. So the difference is that the balanced fluid, in this case LR, has a strong ion difference of 29. In the other hand, the normal saline has a strong ion difference of 0, because it's pretty much sodium minus chloride. The other important thing that can sometimes be causing some hyperchloremia and metabolic acidosis, because of the supraphysiologic content of chloride. So this is a table that is showing us pretty much the composition of the two most common use crystalloids, sodium chloride. So it's 154 milliequivalents of sodium and 154 milliequivalents of chloride, with a strong ion difference of 0. On the other hand, LR has a sodium of 129, chloride that is going with the physiologic content of in plasma is 109. Has also potassium 5, calcium 4 milliequivalents, and lactate. So that will give us a strong ion difference of 29. That is close to plasma. So let's start with our critical appraisal about this study. So I choose the critical appraisal of a cohort study that is different from a clinical trial critical appraisal. So before I start with the critical appraisal, just want to mention about a cohort study. So a cohort is basically a group of people with similar characteristics. It used to be used in the ancient Rome. They were referring cohorts to military units. And basically a cohort study is longitudinal and observational, and the idea is evaluate risk factors and prognosis. There are two different types of cohort study, prospective and retrospective. And the difference is when do you define the groups of a study. So in a prospective, you define the groups before the study is done, while on a retrospective study like this one, you define the groups after the data is collected. Some other important definitions is prognosis. So what is prognosis? Is the possible outcome of a disease and the frequency with which they can be expected to occur. While a prognostic factor are characteristics of a patient that may be used to more accurately predict the outcome in that patient. That include demographic characteristics, age, sex, disease-specific characteristics like tumor stage, comorbidities, and here I have this graph that is showing us the difference between the prospective and retrospective cohort study, and also with case control. Sometimes it's important to know the difference. So the big difference between a case control study and a cohort study is where you're going to start. So in a case control, you're going to start the study from the outcome of the disease. And then you will have two groups, one with the outcome that you want and the other group with the outcome that you don't want. And then you go back and see if there is any exposure that can be associated to this outcome. In the other hand, in a cohort study, you are going to start from the exposure. So you have one group with the exposure that you want to study and other arm with the patients without exposure. And then you go in time and see if they develop the outcome that you are looking for. The difference between a retrospective study and a prospective, as I mentioned, for the prospective, you start with a question and you start defining your groups before the outcome, and in the retrospective, you define your groups, but the outcome already happened, but you are going to start from the exposure. So it's important because in a case control study, you cannot calculate incidence, and you basically calculate odds ratio. That is similar to relative risk, but the idea of a cohort is that also can give you incidence. So let's start with the critical appraisal. So does the study address a clear question? And the answer, I think, is yes, because just reading the title, we can assume the question is they want to know if there's an association between the choice of IV crystalloid and in-hospital mortality among critical ill patients with sepsis. In clinical, when you're analyzing a clinical trial, you're looking for a PICO question. And when you're doing a critical appraisal of a cohort study, you're looking for the PDO question. So the PDO is, P is for patients. In this case, were adults that were admitted in a hospital, and there were like 360 hospitals, and this was from November 2005 to December 2010. D is disease or condition, in this case sepsis, and O is the outcome, in this case is in-hospital mortality. This is the primary outcome. There's a secondary outcome. The secondary outcomes are acute renal failure with or without dialysis, and hospital length of stay in the ICU and in hospital in general. Are the results valid? So the next question is, was a defined representative sample of patients assembled at a common point in the course of their disease? And the answer is yes. So this cohort study is, the size sample was 53,448 critically ill adults. These are the inclusion criteria that include inpatient, age like 18 or older, sepsis as the principal diagnosis, known in-hospital mortality outcome. So they exclude patients that were transferred to another hospitals. That they were in the unit receiving vasopressors by day 2. They need to have blood cultures. they need to receive 3 days of consecutive antibiotics and receive at least 2 liters of IV crystalloids by day 2. They also exclude patients that were taken to the OR. So this is the diagram. So basically, the patients that met the inclusion criteria were 654,000, but they were excluded from different reasons: transferred to another institution, they went to get surgery, or there was not enough data. So they reduced after the exclusion criteria to 53,000 patients. And they divide in 2 arms. One arm was the one who received balanced fluids. That was 3,396 patients. And the other arm, the patients that received non-balanced fluids only, that was 50,000. Obviously, there's a big difference between those 2 groups. So what they did, they did a match between the patients who received the balanced fluid with the ones who didn't receive the balanced fluid. Basically, they matched by characteristics, comorbidities, demographics. So at the end, we have 2 arms, each with 3,365 patients. Obviously, the problem was that the patients who received balanced fluids, and this is something that makes the things complicate the things a little bit, is that only only less than 3% receive only balanced fluid. Most of the patients receive a percentage of non-balanced fluid plus a balanced fluid, meaning like they receive normal saline and then they receive LR during the course of the resuscitation. So they divide also this group in by percentage. So if they receive 10 liters of fluid, if they receive like 20% of LR and 80% of normal saline, so they divide basically in 3 groups: less than 20% of balanced fluid, 20 to 40% of balanced fluid, and more than 40% of balanced fluid. Next question: was the follow-up of these patients sufficiently long and complete? And I think yes. So basically, the idea was to see these patients receive fluids resuscitation the first 2 days, and they follow the patients until they were discharged from the hospital or they had their outcome, that is death. It was retrospective, and it was from November 2005 to December 2010, and basically the information was obtained from hospital discharge files, billing databases, and itemization, and basically all the medical records. Next question is, were the objective and unbiased outcome criteria used? There's no mention about blinded personnel doing this study. It was a retrospective study. All the information was there, and the outcome is pretty clear. It's mortality. Was there adjustment for important prognostic factors? And the answer is yes. So as I mentioned, this was 1-to-1 ratio of matching, adjusting by the different characteristics and comorbidities of these patients. So as you can see in this table, we have demographics, and the first 2 columns are showing us the non-balanced fluid group with the 50,000 before the match, and the balanced fluid group with 3,000 patients. This was before the match, and you see there are some items that are different. But then after the match, when we have the 2 groups, the demographics are the same. None of them. There's no significant statistical difference between those two groups after the match. These are comorbidities, including heart failure, hypertension, alcohol abuse, and if you can see, after the match, both groups were the same. More comorbidities, including diabetes, hypothyroidism, kidney failure, liver disease. Also, they match by co-intervention, so meaning patients that were on the vent, that required dialysis, that required bicarb, hydrocortisone, If you see the last two columns after the match, those groups are similar, and there was no significant difference. Even CVP monitoring, arterial lines, they're pretty equal. So what are the results? So how likely are the outcomes or events over a specific period of time? So we have here our primary outcome that was inpatient or in-hospital mortality. And we see that in the balanced fluid group, it was 19.6%. And the non-balanced fluid group was 22.8%. So that gives us a relative risk of 0.86, and it's showing us that there is an association, and it's showing us that the group with the balanced fluid were protect against mortality. For the secondary outcomes, there was no difference. Acute renal failure, there was no difference. In hospital, length of stay was, and in the ICU, both, there was no difference, no significant difference. There was some difference, but no significant. This graph, I like this graph because it's showing us, because as I mentioned, not everybody received the same amount of balanced fluid. They also received some percentage of non-balanced fluid in that arm. So, but you can see a trend here. It's like if the patients who received more or like a more balanced fluid, the mortality decreased. So if you see by percentage, the patients who receive almost like 100% of balanced fluid, their mortality is actually lower than the group that receive less than 5% of balanced fluid with that trend. Here also, this graph is showing us the difference. They make subgroup analysis depending on how many liters of fluid they received. So they divided in quintiles, and the first quintile was 2.5 liters, 4 liters, 5.5 liters, 7 liters, 10 liters. And they divide those in both arms, the arm with balanced fluids and the arm with no balanced fluid. And as you can see, the black bar is the group with the balanced fluids, and you see that the mortality was lower than the ones who didn't. So this is basically what I mentioned in the previous table, like the in-hospital mortality and the frequency. So the next question is, how precise are the estimates of this likelihood? So in our primary outcome, the relative risk was 0.86 with a confidence interval of 0.78 to 0.94, so it's not crossing the unit with a p-value of 0.001. The other secondary outcomes was not significant. So I always like to calculate myself this number, so because the article was giving me all the numbers, so I calculate my relative risk, and was the same as the article present, 86%, and it's basically you divide the risk and the treatment group over the risk in the control group. I calculate the absolute risk reduction. It was 3%. That is basically the risk control minus the risk treatment. Relative risk reduction was 0.14. That is basically 1 minus the relative risk. And the number need to treat. I know that this is not a clinical trial, but I just I decided to do it, and it will be 31. So it's like you need to treat 31 patients with balanced fluid to avoid one death. So will the results help me with my patients? So were the study patients similar to my patient? I think yes. There are 53,000 patients, and there were 2 arms with 3,000 patients each in the ICU with requiring pressors with fluid resuscitation. And here I have some demographics, and I think we can see that all the ratios are showing us here. There was like age, I think smokers. I think these patients can be similar to our population. Will the results lead directly to selecting or avoiding a treatment? Is there any question? Oh no, they were just okay. Never mind, Rodeo. I thought you were one to ask me a question. Yeah. So I mean, I think it's important because it's showing us that the balanced fluids are decreasing mortality. I know this is a cohort study; it's not a clinical trial, but at least it's giving us some indications that the balanced fluids are decreasing mortality, and also showing us that if they're receiving more balanced fluid, they are also going to decrease mortality. And are the results useful for reassuring and consoling my patients? I mean, it's a cohort study. I think the important part of this study is that it's telling us that we need to go for a clinical trial to be sure that these numbers are accurate. But I think in my practice right now, and I don't know if Dr. Starosta is here, but we're using LR most of the time. So that's it. Thank you. Do you have any questions? Yeah.
They talk about, are these boluses or continuous infusions?
No, they basically calculate the amount in liters. So how many liters did they receive in the first 2 days of resuscitation?
So even boluses with LR is included.
Yes.
Based on that.
I have a
Rodeo.
methodological question. How do you match almost more than 2,000 patients and your end group is exactly the same, 3,600 something in each arm? No, I mean the principle about it is, how do you match it? How did the number, is there a significant number on the non-balanced side? And how did they do that? How did they match that the exact number of people are in each arm? My second question is risk in treatment over risk in control. If we say that some of these people receive balanced and unbalanced, not no one really received solely balanced or non-balanced.
Yes.
What is the control?
So I mean, one group they didn't receive balance at all, and the other group received some percentage of balanced fluid. That's the two arms.
So I read this just once, and I don't remember. You have to look at the methodology. If you can obviously do case matching. Have LR patients who just got LR matched to saline patients.
Yes. So the problem was that the group that only received balanced fluid was less than 3% of that number. So I mean, the problem was going to be the sample size.
6,000. I was wondering. Yeah.
What's the question? So they're doing propensity analysis, right? So propensity matching. They have in one group 50,000 patients, in the other group, I missed most of it, but I read this one, but 3,500. Yeah, so it was propensity matched analysis. So statistically, it's like logistic regression analysis, but a better version of it in a sense and you can employ it when you have very high numbers specifically in one group, you can, so that the patients are even more matched than more or less than logistic regression. That's all what you need to do to know more or less. Sorry, but we had another question.
So in these cases, when you measure relative risk, and you usually do that when you have a control. Can you say in this thing that the difference between mortality of the two groups was superiority of one to another?
Yeah, there was clearly a decrease. I mean, based on this cohort and this analysis, you can clearly see that using balanced solutions has a better outcome in terms of mortality. That's the only thing I can tell you. And they tried to match to whatever they could within their own limitations. At the end of the day, no matter what you match for, when it might not, the groups might not be exactly the same. You match for the things you know that they're associated with mortality as much as you can. But even if you try to, no matter how hard you try, you can come as close to the truth and never get there. I have a specific interest in this. I was telling Dr. Uda, I I submitted to critical care medicine, and this article came on another article during our submission. I'm not pretty sure that it's the solution that really matters. So the way we presented our data was hyperchloremia in the ICU the first 72 hours and ICU mortality, which you can argue, yes, normal saline might cause more mortality. But what is it that is, if it's true, and even I'm skeptical from our own data, for example, I adjusted for acidosis, meaning that it's not the hyperchloremia maybe, it's because those who are hyperchloremic are more acidotic. I adjusted for that. Despite that, hyperchloremia had high odds of mortality. Even me, with my own data, I'm skeptical about. I mean, that's just my feeling. It needs a clinical trial, I think.
Yeah, so I have a little bit of interest anyways in evidence-based stuff. And one of the ways that evidence-based medicine is looked at wrongly is we tend to think about studies in a hierarchical fashion.
Mm-hmm.
And you made inferences during your talk about that, like, the idea that a prospective controlled trial is the gold standard, and a study that is retrospective is not as good. And actually, that's really not what evidence-based medicine is about. It's really about weighing the evidence.
Mm-hmm.
And so when you have a large retrospective study, as this one is, with tens of thousands of patients, the strength of that study becomes pretty important.
Mm-hmm.
And although it ideally would be a good idea perhaps to have a prospective study that confirms it, if you had one that had 100 patients in each arm, would that convince you more than this? And I'm not sure that it would. So I think this is a good study, and my issue with this study, or the thing that I think about, is that probably before reading this, I'd have thought saline, lactated Ringer, I'm not sure that I would pick one over the other necessarily. I'm not sure that I had a difference between choosing one versus the other. Read this study, instead of all other things are equal, why wouldn't I pick lactated Ringers? That sounds like probably what I should be doing, because I can't see a downside to it, and if I thought before reading this that they were the same, and after reading this I'm thinking maybe there's an advantage, I'm going to do that. You know how many Roman soldiers were in a cohort?
No.
1,000. Legion had 10,000, so this is more like a Legion analysis, cohort analysis, but I think it's a good study to think about.
Yeah. So the real question becomes, now with this data, will that change practice? What do you think about this data, and what do you think about how it would impact how you manage your patients in ICU now?
I mean, yes, as I think part one changed her. Part one is changing.
You're doing your own
Yes.
prospective study.
Then why is it whenever I round on your team, everybody's chloride is greater than 120?
They're coming like this from the ER.
One day I come in after somebody else chloride is 120, and so then we switch over.
But I have a question, and this was the most difficult part of understanding. Why would we think, you can tell me the pH is different, but we have to find a plausible explanation of why do we think the outcomes would be different. So one thing I can tell you, like in humans, we don't know, and I've looked into it, and there's rat models, and they're mostly in rats. They show increased chloride worsens intracellular acidosis, and if that happens, the oxyhemoglobin dissociation curve shifts to the right, and if that's happening, your oxygen carrying capacity is not the same, so you're not transferring enough oxygen in patients with severe sepsis and septic shock. Plus, in rats, we know you have large vessel dilatation, so increasing hypotension, and the small blood vessels, arterioles, vasoconstrict. So these are the only things I could find, but mostly were animal models. I don't know, I don't think the author specifically alluded into possible other reasons. I know we can say the pH is different, but we need, on the molecular level, I'm just trying to find an explanation for it.
I think the ideas are important, but I would suggest that the outcomes is what drives us. So I might think that I'm not causing a lot of stretch, giving 6 milliliters per kilogram of iodine per idea body weight. But I'm not sure that that's true, but what I know is that when we do that, people do better, so I'm gonna do that. I can come up with a rationale why beta blockers work in acute MI, but I'm more interested really in the fact that people do better when I give them to them when they have acute MI. So I think this data is kind of important to us because it says to me, I should be giving my beta ringers. I'm gonna ask Leo about why it works, but you know what? Since it appears to work, I'm gonna do it.
No, I totally agree. For now, I would prefer using LR until somebody convincingly tells me it's harmful.
Is the potential for hyperchloremia?
It's not addressed in this study, I don't.
I know, but what about when you're bolusing? Is that something that comes across your mind when you're bolusing? Like that it's unpredictable. Because it's unpredictable. You don't know what the potassium is going to be. Now you're giving potassium as a bolus.
It's
So with LR, yeah, there's.
In 1 liter, it's nothing. It's fine. Yeah. In terms of content, you're saying the potassium load in LR?
Right.
So it's 5 milliequivalents per liter.
We used to, in the old days, we were much more concerned about giving the lactate because we were worried that it was going to be metabolized. I don't think I ever worried a whole lot about that.
No. So I was reading, and basically you need to receive like 3 liters of LR in a liver patient in an hour to elevate the lactate. So in a patient with a liver cirrhosis, you need to give him 3 liters of LR in an hour to elevate the lactate, just because of the LR. Yeah. But it needs to be like 3 liters in 1 hour, I think. Yes.
Is there a significant cost difference between beta ringers and
That's a good question. I'm not sure. I don't know. I didn't. I mean, I'm not sure about that. Yeah. But that's something that we should.
It's there?
It is there.
What's it? I don't know. I can tell you how much I kind of know a bag of compensating costs. Is that must be helpful? I heard it's $130.
That's the total cost.
Yeah, the administrative costs and all that.
Yes.
Yes.
Oh, the cost in terms of manufacturing is nothing.
Yes,
I heard it's less
probably
than
equivalent.
$1.50 the cost of manufacturing.
You send to the policy?
I have one more thing I have to say. People have invested interest in these studies. People who are advocating using balanced solution are also manufacturing the balanced solution. It's not like but you have to be careful also how you approach, your analysis. You have to look who's publishing what. I can tell you one thing. I have already a balanced solution. Every CVVH bag that is hanging is a balanced solution. The sodium content is 140 and the chloride is 100. We can repackage it and name it as a balanced solution, but the solutions that you have for CRRT, they're already 5 liters of balanced solution.
I have the cost here. This is based on the 250 log. I don't know if it's correct, but it's $4 for LR, $2 for saline, and well, yeah, so it's double the price. You would say.
Okay.
Absolutely, yeah.
And albumin is 125.
Okay. Thank you.